Sefcik and Gerszten, as well as the rest of their team, and they're going to discuss their recent publication, Stereotactic Body Radiotherapy for Spinal Metastases from Gastrointestinal Primary Cancers. There'll be some opportunity for the participants to put questions in the chat function, and we'll do our best to try to get to those questions at the end of today's presentation. So without further ado, Dr. Sefcik, if you want to take over and start your presentation, thank you for joining us.
Good afternoon. Thank you for inviting us to share our work with you today. It is an honor to participate in the JNO Tumor Talks with this esteemed panel. My name is Roberta Sefcik, and I am currently at the Medical University of South Carolina. My talk involves work performed by Dr. Gerszten's lab that I was incredibly lucky to work with during residency and fellowship at the University of Pittsburgh Medical Center, or UPMC. I'm joined today by Dr. Gerszten and two of the medical students that were instrumental in designing and implementing the UPMC Stereotactic Body Radiation Therapy database, spanning Dr. Gerszten's experience in the treatment of metastatic and primary spinal tumors with SBRT over more than the last 20 years. The students Sam Medita and Suchet Tayori joining on this call are applying into neurosurgery and have become institutional experts on SBRT. The title of our paper is Stereotactic Body Radiation Therapy for Spinal Metastases from Gastrointestinal Primary Cancers. Gastrointestinal, or GI cancers, arise from the esophagus, stomach, pancreas, hepatobiliary system, and small and large intestines. GI cancers comprise more than 1/4 of all cancers and account for 1/3 of cancer-related deaths. GI cancers typically present later in their course, and painful osseous metastases are not incredibly common. With enhanced screening and advanced systemic therapy, patients are surviving longer, increasing the prevalence of GI cancers and spinal metastases. GI primary cancers are relatively radio-resistant and have been challenging to manage with conventional external beam radiation therapy, or EBRT. Stereotactic body radiation therapy, or SBRT, offers high-dose, highly conformal radiation with steep dose gradients that are delivered to minimize exposure to critical structures. SBRT can be performed in conjunction with surgical decompression or alone to effect local control. The effect of SBRT on radio-resistant tumors has previously been investigated. Renal, melanoma, and thyroid metastases, despite being relatively radio-resistant to EBRT, have been shown to be successfully treated with SBRT. This work has paved the way for our study of GI cancers. There are several prior studies investigating the effect of SBRT on GI spinal metastases. These studies are small in number with a limited patient sample. Overall, patients were treated with high doses of radiation with a wide range of resultant local control. Most of the prior series were broken down by histology, except for that of Sandu. Overall, outcomes in previous series were relatively poor. In general, our experience with SBRT has grown from its initial goal of palliative pain relief. We now aim to provide long-term local control to prevent neurologic and functional morbidity. We strive for durable pain control, and we attempt to avoid the need for further, possibly invasive and extensive additional treatments. We present a large experience in SBRT for GI cancers spanning the years 2001 to 2024 from the UPMC SBRT prospective single institution database. From this experience, we sought to learn cumulative incidence rates of local failure in GI cancers, and we stratified by gastroesophageal, hepatobiliary, and colorectal malignancies. We evaluated overall survival, patients' pain responses, and adverse effects in the form of radiation toxicity. Indications for intervention included pain with or without underlying spinal instability and neurologic deficit. We collected several variables, including patient demographics, cancer histology, radiation and surgical history, as well as past treatments and radiological data. We were most interested radiographically in stratifying our patients by their burden of epidural disease as classified within the epidural spinal cord compression scale. In this scale, grade 0 tumors are located within the bone, while grade 1 tumors can deform the fecal sac, grade 2 tumors impinge the spinal cord, and grade 3 tumors, the most severe form of epidural compression, results in loss of visible CSF around the spinal cord. We were also interested in radiographically stratifying patients by their degree of spinal instability, as classified in the Spinal Instability Neoplastic Score, or SIN score. In this score, the degree of spinal instability increases with the total score, with patients getting increased points for junctional pathology, mechanical pain, lytic lesions, subluxation or translation, vertebral body collapse, and posterolateral involvement of the spinal elements. In our series, the planned treatment clinical tumor volume equated to the vertebral body with or without the posterior elements. The planned treatment included irradiation of the entire involved vertebral body, not just the gross tumor volume within the vertebral body. In the setting of patients that received pre-SBRT surgical resection or decompression infusion, the preoperative disease burden was taken into account. The planned tumor volume included the clinical tumor volume plus 1 to 2 millimeters, with the exclusion of the planning risk volume, which equates to the spinal cord or fecal sac plus 1 millimeter. Other critical structures included in the planning risk volume were dependent on the location of the tumor. Critical structures included the esophagus, lungs, heart, great vessels, kidneys, and intestines. SBRT is safe, and evidence supports the tolerance of a healthy spinal cord to be 10 to 12 gray per session. In general, SBRT is contraindicated in the setting of significant spinal cord compression and significant neurologic compromise. In our center, the mean total dose to the spinal cord administered in cervical and thoracic lesions is 9 gray, followed by 10 gray to the cauda equina in the setting of lumbar and sacral lesions. We have seen no subacute or long-term spinal cord or cauda equina toxicity using cone beam CT image guidance. In review of our SBRT database between 2001 and 2024, we have treated 75 patients with 106 metastatic gastrointestinal primary tumors. The interquartile range of patients' ages ranged from 55 to 70, with a median of 65. Most patients, or 65%, were male. The functional status of these patients was quite good, with a median KPS of 70. 88% of patients presented with pain associated with their spinal metastasis or metastases. We included 62 colorectal carcinomas, 13 hepatocellular carcinomas, 12 esophageal carcinomas, 6 gastric carcinomas, 6 pancreatic carcinomas, 5 cholangiocarcinomas, and 2 neuroendocrine carcinomas. Most patients, or 65%, presented with oligometastatic disease with 2 to 5 distant metastases. We treated 32 tumors, or 30% of tumors, with solitary disease with only a single metastasis to the spine. 4% of the sample had more than 5 distant metastases. 85% of patients had undergone prior or adjuvant chemotherapy, and 8% underwent prior or adjuvant immunotherapy. 76% of the patients underwent prior EBRT, and 11% underwent prior surgical resection. Most tumors were located in the lumbar spine at 34%. The other most common locations were sacral at 29% and thoracic at 24%. 8% of the sample had a tumor that was located in the cervical region. 43% of the tumors were lytic, and 44% were mixed, with only 13% blastic in tumor type. Expectedly, secondary to relative contraindications in the setting of severe spinal cord compression, most tumors were bone-only disease, or 53%, with 25% with grade 1 epidural compression and 18% with grade 2 compression. While atypical, in certain circumstances, 3 tumors were treated with SBRT that had grade 3 epidural spinal cord compression. Most tumors were either radiographically stable with a SIN score of 0 to 6, while 45% of tumors were potentially unstable with SIN scores of 7 to 12. A minority, or 9% of tumors, had unstable SIN scores ranging 13 to 18. 23% of GI metastatic tumors treated were multi-level, meaning that they spanned at least 2 vertebrae. For 78 tumors, we performed single fraction SBRT with a median prescription dose of 16 gray and maximum dose of 20 gray to a gross tumor volume of 44 cc's. we performed multifraction SBRT to 28 tumors in a median of 3 fractions with a median prescription dose of 24 gray and a maximum dose of 30 gray to a gross tumor volume of 23.6 cc's. The median biologically effective dose with an alpha beta equal to 10 was 41.6 gray. In our series, in which patients were followed at a median of 5 months, although the interquartile range ranged 1 to 13 months, the median time to local tumor progression was 4 months. Cumulative local progression was 5% at 3 months, 9% at 6 months, and 10% at 12 months. When stratified by tumor histology, 12-month local failure was 6% for gastroesophageal cancers, 10% for hepatobiliary cancers, and 13% for colorectal cancers. Overall survival was 68% at 3 months, 50% at 6 months, and 41% at 12 months. Complete or partial pain responses for 93 tumors, or 88%, that presented with pain were 60%, 51%, 32%, and 32% at 1, 3, 6, and 12 months, respectively. We observed 12 radiation toxicities, or 11%, and we observed no cases of neuropathy or myelopathy. Cases of radiation toxicity included fatigue, dermatitis, dysphagia, pain flares, and vertebral compression fractures. We found that local failure was predicted by multi-level tumors spanning more than 2 vertebrae. We also found that overall survival was significantly impacted by the degree of epidural spinal cord compression. I'd like to briefly show 2 representative patients from our series. The first is a 65-year-old man with hepatocellular carcinoma. He had a symptomatic T11 tumor and received upfront SBRT with 24 gray and 2 fractions. He had no toxicity or local progression at 22 months. More challenging was the case of this 67-year-old woman with this symptomatic tumor at T7 from colorectal carcinoma. Her pretreatment SIN score was 7, and epidural spinal cord compression scale score was a 1C. She had undergone both prior EBRT and decompression infusion. She received 24 gray and 3 fractions and had no toxicity or local progression at 13 months. From our over 20 years of clinical experience, we believe SBRT to be both safe and effective in the treatment of GI spinal metastases. SBRT offers local control and pain palliation with minimal rates of radiation toxicity. I want to thank you all for your time and would like to open the floor to our esteemed panel and my co-authors for discussion and tumor talk.
Thank you very much. What a powerful talk, and again, my hat's off to the work that's been done. The publication is phenomenal, and again, congratulations to you and to your colleagues on this. In thinking about your presentation and hearing it after having looked at the paper previously, I was wondering if your thoughts were about 2 things. One, the compression fracture incidence. It seems low, and could you talk a little bit about when it does occur? I think it was about 5% in your series. How can you describe a little bit about how you manage a compression fracture in a patient who's been irradiated and has some loss of vertebral body height over and above what their baseline may be, and presumably a bit of pain? Is there a paradigm, a treatment paradigm that you and Dr. Gerszten and others typically use?
To address your first point regarding the incidence of compression fractures in our study, it certainly was lower. If you look at the studies published in 2020, for example, there's 3 groups that published then on GI cancers. The compression fracture rates were much higher and are quoted in the literature, surely up to 25%. If you look at the BED10 in our study, around 40 gray, that's also significantly less than that which was published in those studies. So certainly at rates between 60 to 80 for a BED10, when you have an increased dose delivered to that vertebral body, you're certainly at risk for fracture. In addition, many of the patients in our study had either mixed or blastic bony tumor types. So those, of course, that have more lytic pathology are certainly at risk as well. So that also could have contributed to the patients having a lower rate of fracture in our study. In general, in the patients that present with compression fractures and pain flares in general. We attempt to get them through with conservative therapy alone, so either medication management, bracing, a short course of steroids in the setting of pain flare. But we've also gone on to, in patients that fail the medical management, perform kyphoplasties in those groups.
Thank you very much. And I certainly agree that potentially a lower dose where you're demonstrating very nice tumor control and potentially a complication avoidance of compression fractures is a wonderful thing to see in these patients. I wonder, this is not something that you directly commented on, but perhaps you can expand a little bit upon your experience. As you know, increasingly in managing patients with metastatic cancer, precision medicine approaches are being used more and more. And in the case of GI cancers, they oftentimes have BRAF and KRAS mutations. And there's been a lot talked about the interface of precision medicine therapies with ionizing radiation, especially in high dose per fraction. Can you talk a little bit about any paradigms that you use in terms of continuing or having a brief cessation of precision medicine therapy at or around the time when you're giving SBRT to the spine? And have you noticed any either increased toxicity anecdotally or increased efficacy by being able to continue these patients maybe a little bit more on their precision medicine therapies than they might otherwise have been able to do if they had undergone an open procedure or a more standard protracted fractional radiation therapy approach to treat their cancer?
That would be really important to look into in further detail. In our study, we had simply recorded whether or not they had received or were receiving concomitantly these other types of therapies. Another venue in which I could see this could be important is there is data to show differences in the patients with GI cancers that are right-sided versus left-sided tumors. And so that's another avenue by which we could stratify the data that would be of interest. Dr. Gerszten, I don't know if you have any comments on that question as well.
It's interesting because, Jason, you and I published quite some time ago just about with the melanoma series and integrating this. As a rule of thumb, we have not tried to avoid, or I think that's a double negative, but we have not felt that some of these immunotherapies and targeted therapies needed to be held or stopped during spine extracranial radiosurgery, as opposed to with intracranial radiosurgery, where there's been much more discussion. We simply have not seen any flare-ups, and we have certainly not seen any complications. As far as teasing out, is it an increased efficacy? It would just be very, very difficult just because our rates of local control are so high.
Right, right. I think it's important to note to the audience that there isn't necessarily a big protracted need to stop these therapies. And we know that that's so critical. In most instances, intracranial radiosurgery or spinal radiosurgery, there may be a period of brief cessation depending upon the underlying medical approach that's being employed. But for the most part, these patients can carry on with their treatments, if it's immunotherapy or a targeted therapy. Antibody drug conjugates, I think that may be a little bit more controversial at this point, and we're trying to get a signal on what that is in the intracranial space. But obviously, you've had such a vast experience. I appreciate the insights that you can share, even if they're just preliminary or anecdotal. So, other questions, Chris?
Yeah, thank you again. I think this is an amazing body of work over almost 2.5 decades. I don't think you were going to find this in many other centers with as much data to back it up. One thing I didn't see in the paper, but I'm sure it was captured somewhere, is that this is a unique disease for a unique patient population. It's getting younger and younger, unfortunately, that we're seeing GI-based metastatic disease develop. But how many of the patients that you think in your, or can estimate, that had colorectal cancer had undergone, let's say, a low anterior resection or something that may have predisposed them to already having some quality of life issues and problems with bowel dysfunction or sphincter control? And could you kind of get a feel for whether or not there was any sort of worsening of their baseline in that patient population? Because the majority of your patients were lumbar disease and colorectal cancer. And that's just the nature of what you're dealing with. It's every time I hear about somebody has a cranial met with GI cancer, I kind of wince a little bit, because we know those are the ones that really become a problem for us to manage. And did you guys have any signal difference in those patients?
So we don't have the exact numbers. We didn't specifically look into the colorectal carcinomas, whether or not they had received a low anterior resection or not. I don't think at the dose that we delivered to the lower lumbar or sacral regions that it was significantly worsened, because it would have been caught in our toxicity data, because new bowel incontinence would have triggered review for a cauda equina type syndrome for toxicity to the cauda equina.
But their baseline, the baseline was fairly low, even in the lumbar colorectal patients.
I don't know. I don't have the data to support it.
Okay. And then the other question I have in follow-up, saying that, this is 2001 to 2024. There haven't been a lot of changes in systemic treatment. I think a lot of colorectal patients are still getting FOLFOX and FOLFIRI with local radiation to disease, with or without surgical resection, with a diverting ostomy and then a rehookup. That seems to be the trend. But have you seen is there any difference if you try to dichotomize patients from 2001 to 2010 and then 2010 to 2024 with the advent of immune therapy and the addition of pembrolizumab to a regimen in patients?
We haven't. It would be great to look into also, though, because I think that the radiation doses that we've been delivering from SBRT have changed. And so I think in that setting that it would be very important to look at from a time-based approach, specifically in colorectal cancer. We're still trying to find exactly what the correct bed-10 dose is for these GI cancers. And so, like I said before, our bed-10 was lower than some of the more recent studies. And so taking a look at that, even specifically within our own data, would be of interest.
And just to follow up on that, in that if you look at our age range, it's actually fairly elderly. I think the youngest patient was 50. It was a very tight age range, and certainly we are seeing younger and younger patients. Perhaps those patients are started on more aggressive systemic therapy, chemotherapy regimens, and so we're just not seeing them, because all of these are done. Actually, the majority are referred collaboratively with the radiation oncologist, but maybe they're just being treated elsewhere. So these are not 30 and 40-year-olds, but it's certainly the disease is targeting younger and younger patients than in the past, especially the pancreatic cancers.
Absolutely, and I think that some of the public health notices that have come out have suggested that the 30-something and 40-something patients are becoming much more prominent in this disease state of GI cancer. I know that this doesn't happen as much and perhaps in this patient population, but if you were going to do a decompression infusion, can you comment a little bit on the surgical considerations for these patients for whom you might then be using spine radiosurgery to follow? Are there specific implant biomaterials that you're using? Are there specific approaches that you're taking? I know, for instance, in past conversations, Peter, you've been very kind as to suggest some of the separation surgery concepts, but can either or both of you talk a little bit about that might be of interest to our audience?
You want to start, Roberta?
Sure. Well, I would just take into consideration one of the things that I think about if I know that I'm treating someone with metastatic disease, especially if they have a tumor at a remote level that I'm not going to be addressing surgically, that those high risk parts of the resection, if there's densely adherent tumor to the dura and such that are going to cause a complication, we have treated people with as high as grade 3 compression in this study. Those weren't the patients that had surgery necessarily, but just important to know that I think that you have to take into consideration when you go into surgery that there is another treatment that you can deliver in addition to it, kind of similarly for how we think for intracranial lesions.
So kind of to follow up along those lines, definitely the en-bloc resections are definitely a thing of the past for this, especially for this patient population. And we are definitely less aggressive, as Roberta was saying, with ventral tumor, anything where there is a risk of tearing the dura and causing further complications. We know that we can focus on separation surgery, decompress the neural elements, place instrumentation, and then leave whatever behind for radiosurgery, which is very, very safe, very, very effective. I guess the new trend is with the carbon fiber instrumentation that you alluded to. We don't have a great deal of experience here. I know other of our colleagues are really moving in that direction. And I think that is a real paradigm shift in spine oncology and combining post instrumentation, SBRT. It's a real game changer.
Our treatments we based our treatments off of their pre-surgery scan. And so if you had used carbon fiber technology, for instance, you would potentially be able to see tumor better on a postoperative MRI for enhanced treatment planning. And I think something else to consider, of course, would be cement augmentation of screws in these patients that are prone to poor bone quality, especially at the index level if able to be instrumented.
Well, thank you very much. It's what an incredible effort and just a powerful webinar. Thank you so much. We do try to keep this, as Randy would say, to 30 minutes. That probably the attention span of most neurosurgical colleagues. Other disciplines may have longer attention spans, but I thank you all for joining. I hope there's more to come from the group, and that database is really a national and international treasure. Please use it to advance our understanding, and let's see more publications from your group in JNO. All right. Thank you so much.
Thank you so much.
Thank you all.
Thank you all for your attention.